Ivan, can you hear me?
Yes, I can. Can you guys?
Can you try now?
Yes, I can hear you. Can you guys hear me?
Yeah, perfect. Okay. Okay, we're gonna start. Bueno, buen día a todos. Muchas gracias por asistir al Ateneo del Servicio de Terapia Intensiva de hoy, que lo hacemos en conjunto con Cardiología, en el aula de Cardiología. Yo soy Federico Carini. Voy a tener el gusto de presentar al doctor Devang Shangavi, que va a presentar sobre el tema de dispositivos de soporte ventricular, en particular el IMPELLA en terapia intensiva. El doctor Shangavi es intensivista de la Mayo Clinic, profesor asociado de medicina, director de la ICU médica, eh, vicejefe del Departamento de Medicina Crítica, y tiene amplia experiencia en este tipo de dispositivos. La idea es que haga primero la charla él, que va a ser en inglés, y luego hacemos la sesión de preguntas y respuestas, donde puedo actuar como intérprete si es necesario, o pueden hacerla directamente en inglés para que el doctor responda. Okay, Divan, the floor is yours if you want to start your lecture.
Thank you, Dr. Karini. A warm welcome. Good afternoon, everyone. I want to acknowledge the planning committee for inviting me. And I also want to thank Dr. Ivan Yuspe. He's a friend and a colleague, and we do a lot of research together and have led to a lot of good publications. And we hope to continue the research with him and other colleagues from Argentina. So I was asked by Ivan, we were working on a couple of our Impella manuscripts, and he mentioned that we are starting our cardiogenic shock program in Argentina. And he was like, if you can talk about some of your experience at Mayo, Florida. And I thought that would be a good idea. As Federico mentioned, I work in all ICUs. And I work in cardiac ICU as well, and was one of the team members who started our cardiogenic shock program at Mayo, Florida. So today I want to talk about the key factors associated with improved cardiogenic shock outcomes. Uh, Wanted to share where we started, what is the state of evidence, how we overcome certain barriers, and where we are at right now at Mayo, Florida. Our hope is that you can learn from some of those things that we can you can implement at your site to improve your program as well. So focusing on optimization of early identification, increased communication utilization. I'll share some of the tools we use, and then standardization of cardiogenic shock patients management. That is the key in terms of improving your outcomes. And then we'll talk a little bit about approach to what kind of mechanical circulatory device you should use for a particular patient. When do you change from a device to another device in terms of the strategy? And so I'll share some examples with that. So as far as disclosures are concerned, I don't have any financial relationship in with respect to any of the things I would mention today. I do want to mention that we are working on a grant by Abiomed, which is now part of J&J, which makes Impella. That is only for research related to retrospective data that we are working with Abiomed. There are no off-label use per se, but as you all know, ECMO for most part is off-label. Although this talk is not about ECMO, there would be brief mentions of ECMO, and that is the only disclosures I have. I want to start with this video. This is emblematic of the state of cardiogenic shock management we had at our place few years back. This is Mr. Beans, if you know. He's trying to resuscitate a dead or dying patient, and unfortunately, not doing a good job. The message of this video here is that optimal management influences outcome. Want to take you back to a little bit of history. But before we do that, something emblematic to the video we just saw was a case which was kind of true patient few years back at our institution before the cardiogenic shock initiative was started. So this is a gentleman, 54-year-old, non-ischemic cardiomyopathy, came in with abdominal pain, nausea, admitted by internal medicine team in a general ward. This was 6 o'clock in the morning. At 10 o'clock, patient was lethargic. There was a drop in blood pressure. Patient had received some opioids for pain. At 12 o'clock in the noon, he received 2 liters of normal saline. The blood pressure did not improve, but patient appeared more alert. Possibly the opioids wore off. At 5 o'clock in the evening, patient was unarousable. The team was notified by the nurse. At 5:23, patient's blood pressure was 71/60. At our institution, a rapid response team gets notified if there is hypotension, and the rapid response team came by. They did a bedside focus. Patient was found to have low EF. Labs were sent. Patient's lactate was 6. AST-ALT was elevated. Creatinine was elevated. Essentially, patient was in multi-system organ failure with shock, increased lactate, and all was this because of presumed cardiogenic shock. At that point in time, at 18:45, patient was ICU was called, patient was transferred to ICU, a PA catheter was placed. Interventional cardiology was called at like 9:50, almost 10 p.m., and Impella 5.5 was placed. What I want to highlight here is that it took 12 hours from the patient's symptom to first kind of exhibit that there was some abnormality to actually receiving the mechanical circulatory device. That point in time, multi-system organ failure had already set in, and that time response, and we think that 12 hours or more than 12 hours was too much. And how can we respond to these patients in a timely manner, intervene so that this multi-system organ failure doesn't set in, is the context or the crux of what we are trying to do here. So before we get into what we did at our place, just a little bit of history. You work in cardiac ICU, manage cardiogenic shock patients. You must be well aware of most of the trials that I'm talking about. But for 20 years, starting in 1990s to late 2020s, 2017, you have these 5 trials which actually show that cardiogenic shock had hit a plateau in terms of survival. These 5 RCTs showed survival which was close to around 55, at best 60%. This was stagnant outcomes. Why is that the case? The concern or the question why we could not improve mortality despite some of the mechanical circulatory devices being available was, we believe, lack of consensus as far as what cardiogenic shock definitions are. Misclassification of cardiogenic shock types. Timing, as we mentioned or saw in our first case, when we identify shock and when we intervene is the single most defining feature in terms of outcomes of your patient. Device selection. How do you give the patient the right device at the right time is also crucial in terms of mortality. And how do you manage the shock? Devices are not the only thing. What do you do before the devices? What do you do after the devices is crucial in defining the trajectory of patient survival. So we know that inotropes alone in cardiogenic shock is not sufficient. From this paper published in American Journal of Cardiology 2016, it nicely illustrates that as you increase the number of inotropes and or pressors, the mortality increases in your patient. This was almost 300 patients, and from the right side of my screen to the left side, you had 0 inotrope suppressors to 4 plus inotrope suppressors. The mortality increased from 32% to 74%. So just sticking with inotropes or vasopressors alone would actually lead to worse outcomes. So that strategy alone would not work. There is a role of inotropes and vasopressors. At a low dose, one or two agents is needed to tide your patient through a cardiogenic shock crisis if they are transplant candidates, to get them to a transplant or whatever else is kind of the destination in terms of like final disposition. One of the other problems I mentioned is the definitions of cardiogenic shock. So for the longest period of time, our definition of cardiogenic shock was rooted in the physiology of acute myocardial infarction and the shock resultant to that. But we since then know now that this is a more global phenomena. This is not per se related only to acute myocardial infarction, but it it can be variety of reasons in the heart, starting from the heart, but can lead to multi-system organ failure very, very quickly, as you saw in the patient that I just described. So, focusing on the more global picture, big picture, would be the key in terms of how do you define cardiogenic shock? How do you define different stages of progression of this cardiogenic shock, which is pre-shock, mild shock, shock, profound shock, and refractory shock. So I'll show you what definitions we use. It is important that all the team members, be it cardiology, cardiac ICU, general medicine team, we all agree on the right definition so that we can identify the patient and then respond to the situation that the patient is in. So, as I said, not all cardiogenic shocks are similar. In this, you see that a lot of these patients, I just recently read a paper wherein patients with normotensive cardiogenic shock actually, like, almost 30-40% of the patients had elevated lactate, and that is a marker of hypoperfusion. Then you have pre-shock hypotensive but normal perfusion. You also have LV dominant shock, RV dominant shock, or biventricular shock. And these are some of the SWAN numbers, and we're going to talk about CPO in detail in subsequent slides. But I just want to know that our side, we are big believer. Once you identify that a patient is in a cardiogenic shock, one of the biggest things which differentiates in terms of what we do next is in the ICU places SWAN, so that we get the reliable hemodynamics based on which we can actually respond to appropriate treatment plan. So I'm not going to spend a lot of time in pharmacologic aspect, that is the vasopressors and the inotropes, but we all are aware that we use predominantly three, and now there's a fourth vasopressor which is added, which is norepinephrine, vasopressin, phenylephrine, and angiotensin, which is the newest kid on the block. Uh, Most of the vasopressor needs are from vasodilation that is created by some of the inotropes that we use, predominantly milrinone. Sometimes dobutamine also causes dilation, and that's where you would need the pressors to help with the map. As far as inotropes are concerned, milrinone and dobutamine are the only two FDA-approved drugs for outpatient use. We use that even in inpatient. We have epinephrine, which at a low dose is an excellent inotrope without any vasodilation, which could really help in terms of managing these patients chronically. The only downside which you need to know, which you probably are well aware of, is that in patients with ischemic issues, this would increase chronotropy, the inotropes, increase myocardial demand, and that could lead to sometimes worse outcomes. But if it's a non-ischemic patients, then you can use inotropes. I will talk a little bit about the features of different inotropes. This is just an informational slide. Again, we don't have levosimendan in United States. I don't know if you have it in Argentina. Europe uses that a lot, and we are eagerly awaiting FDA approval for that drug. Dopamine is something that we don't use at all in our ICU just because of the tachyarrhythmias related to it. Something that we do predominantly, our first line inotrope is dobutamine. Epinephrine at a low dose is something that we use. At that point in time, it's more of an inotrope than a vasopressor. Norepinephrine is our preferred first line vasopressor along with vasopressin. And then milrinone is used in patients with RV failure, knowing that it could lead to vasodilation. Another problem with milrinone is that it's cleared renally, and in patients who have acute kidney injury or are on renal replacement therapy, it tends to hang around for a longer period of time and can lead to vasoplegia because of that. Uh, Four of the RV vasoactive agents. So nitric oxide is something that we use inhaled through the ventilator or high flow nasal cannula for non-intubated patients. Milrinone, as I mentioned, dobutamine, and then prostacycline. Not going to spend a lot of time here because we have other things to kind of cover. Uh, few slides. Why dobutamine and milrinone have led to bad outcomes, and that's why there was a need for mechanical circulatory devices. So these are historical slides. This was a study published in 1999, which actually compared dobutamine to no dobutamine, which showed that in cardiogenic shock patients, dobutamine actually led to worse outcomes. And that was the need for why we needed something else, and that why we needed mechanical circulatory devices. This is the patients with a milrinone as a agent, which was compared to placebo, and this was published in NEGM. This was even 10 years before the first trial, which is the PROMISE trial, wherein you can see milrinone compared to placebo had worse survival. And that's why, although necessary, we try to use inotropes at a low dose, preferably one or two agents, but we don't titrate it, and we switch to mechanical circulatory devices really, really quickly. So this again summarizes the positives and the negatives of different vasopressors and inotropes. Again, in interest of time, I'm not going to spend a lot of time here. But one thing that I mentioned before is dopamine has no role in our practice, although some practice still use it. We tend to use epi as vasopressor, inotrope, and dobutamine is another agent that we use as a first line, wherein milrinone is added for RV support predominantly. So changing gear and just a few seconds on this slide is an organized approach to cardiogenic shock patients. And these are examples of four centers in the United States. This was in late part of 2010 to 2020, wherein Innova Health, University of Utah, Ottawa Institute, all instituted their cardiogenic shock programs, which then changed the needle in terms of survival. As you saw, this the survival outcomes of cardiogenic shock patients for longest period of time, for 20 years, was around 55%. And now you start seeing that difference from that to 70 plus percent, close to 80% in Innova's experience in 2 years survival. So organized approach does make sense. And what is that approach? This is just one example of the National Cardiogenic Shock Initiative, how the teams organize, what is the hub and the spoke model. What do you do in terms of activation? What are the criteria you follow? What are the hemodynamic metrics? What do you do in terms of weaning, escalation of support, and what are the things you do on a daily basis in terms of ICU care, device weaning? So that left side is a good example of what a well-run cardiogenic shock program can look like. And this on the right side is the mortality outcomes of this published in Journal of American College of Cardiology 2022, which showed improved outcomes with the cardiogenic shock protocol. So this is where Mayo Clinic Florida was in like 2018. So our data from 2016 to 2018, we had an average survival of close to 35% on non-mechanical circulatory device patients with cardiogenic shock, and patients who had cardiogenic shock who received mechanical circulatory device, the survival was around 64%. This was 2018. So this was our baseline. As you can see, we actually were probably performing less than the average, certainly not at the top where we wanted to be. And that's why we organize ourselves. We got our cardiology, general cardiology, interventional cardiology, the transplant cardiology, heart failure team, thoracic surgery, emergency medicine, essentially the nursing and the coordinator team to organize together to find an approach where we can identify these patients in the timely manner and then intervene. So, as I mentioned previously, one of the key challenges in managing these cardiogenic shock patients was what is the definition of cardiogenic shock? And at that time, opportune to us, this paper came out in cardiovascular cath by Baran, which described sky stops cardiogenic shock staging. It essentially described or divided patients into five groups: shock stage A, B, C, D, E, which is A is at risk, B is beginning, C is classic, D is deteriorating, and E is extremist. And the idea behind us was first classify our patients coming into the hospital or who are in the hospital in one of these stages, knowing totally well that these stages can change. A patient can jump from at risk to stage B to stage C very, very quickly. And if we have a system in place where we can actually find that deterioration of this shock stage, we can then intervene. So we used the definitions, and those definitions actually have physical exam characteristics. Those are essentially subjective, so you cannot identify that electronically. But then they also have biochemical markers. So for stage A, you have normal renal function, normal lactic acid, hemodynamics are normal, but they are at risk, maybe because of low EF or history or whatever else. Stage B is where you would start seeing elevated JVP, rails in the lungs, and you may start seeing hemodynamics taking a dip, wherein you would see that initial low or hypotension or tachycardia being captured through this. If you have a pulmonary artery catheter, you can actually see the drop or fall in the cardiac index, although that index is still 2.2 or above, which is okay. Stage C has worsening lactate, and then index drops, wedge pressure increases, and then we'll talk about PAPI and other things and cardiac power output. But those are things which we can measure through SWAN. And D and E is something which is like, obviously worse in terms of patient deteriorating and outcomes, wherein E has lactate more than 5, pH less than 7.2, and then shock, which is refractory to resuscitation, and so on and so forth. So these biochemical markers and hemodynamics were then captured from EMR in a real time setting and then set into a motion wherein Once you actually see the change in the shock staging, it actually sends out an alert to our team, which is the rapid response nurses. So if you can see there on the screen here, it shows that patient has cardiogenic shock stage B, and a page was sent to the star nurse, which is the rapid response nurse, to go and take a look at the patient, order appropriate medications or labs so that we can closely monitor these patients. Once the close monitoring protocol was implemented, if there was further deterioration in terms of cardiogenic shock staging, when the patient got worse from stage B to stage C, another alert was sent out or is sent out, and then more labs are added, and then at that point in time, decision is made. If the labs are worsening, you transfer these patients to the ICU and then escalate it. So to then, like, classify these stages, if a patient is stage A, then there is no need for any multidisciplinary team involvement. But if the patient has stage D or E, we actually then send out a page to the team, and you can see the team members who are paged. And then we quickly get onto a Zoom call like this and then discuss this patient and decide what we need to do in terms of next stage. Obviously, the patient comes to the ICU, but whether to pull the trigger to do a mechanical circulatory device intervention or not is obviously as intensive as we don't put in the device, we manage the device. So we need our surgery colleagues or cardiology colleagues to kind of weigh in terms of whether an Impella CP or Impella 5.5, which is what uh, our surgeons place in the OR, is needed. So coming back to this patient, and like with the new system in place, this is how it would have rolled out. Patient, when the patient had first sign of hypotension, it would have alerted the team. More labs would have been ordered. Lactate, based on the elevation, would then alert the team for stage C. At that point in time, the decision making pathway, if you don't have a PA catheter, patient is still on the floor, you can, based on the lactate, blood pressure, end organ function, then decide whether the patient needs to come to the ICU. Some of these patients may already be on inotropes if that is a home therapy. If the patient has a new low EF or cardiogenic shock, then you may trial inotropes at a fixed dose on the floor. You cannot titrate that on the floor. You can do that in the ICU. But that's when you escalate care and transfer this patient to the ICU. If you have a PA catheter, then you get more nuanced numbers and then decide accordingly. Again, cardiac power output and PAPI is two crucial things which help us decide, and we are going to talk about that in the next few slides. But I just want you to be aware, because those are the two things that we kind of look at along with all the other traditional hemodynamic metrics that you get from PA catheter. So this patient was transferred to the ICU, PA catheter placed, and then we get this number. I've been talking about cardiac power output throughout so far, but not explain what this is. This actually, according to us, is a very nuanced tool in terms of understanding the cardiac function, accounting for both flow and pressure generating capacity of the heart. Even when a patient has a temporary mechanical circulatory device, I mean, a value of less than 0.6 is abnormal, and that would lead us to kind of further decision making in terms of what to do next. So, this is the first step when we triage a patient in terms of what we do need to do next. So, the first step is if the CPO, cardiac power output, is less than 6.6, then we need to escalate. We need certain other numbers, and we'll talk about that. The second number that we need to know is the PAPI, which is the pulmonary artery pulse pressure index. I don't know if you guys use this or not, but this again helps us really differentiate how the RV is doing as compared to the LV and the global heart function. So you need the Swan-Ganz catheter to get the PA systolic, PA diastolic, CVP. You can get it through Swan or through a central line. But you get a number which is less than zero point 0.1, point towards RV, which is failing. If you have a LVAD or a temporary mechanical circulatory device, a number which is less than 1.5 would point towards RV, which is not working well and needs further support. So, so this is the crucial slide, which is, I think, the crux of this talk. I think, based on what I heard from Federico and Ivan, you guys were really interested in knowing more about how do we decide which device, and if you put one device, when do you escalate or change your strategy and add another device, or take that out and put a new device altogether. So as I mentioned, the first step in our decision making, whether the patient needs a mechanical circulatory device or not, is what is the CPO, which is the cardiac power output. If your cardiac power output is less than zero point 0.6, we all agree that there is a cardiogenic shock in this patient. The next thing we need to know is what is the PA pulse pressure index. If your index is less than 1, with the wedge which is less than 15 and RA pressure which is more than 15, then there is a RV issue, right ventricle issue. That's when you would decide, depending on whether the patient has hypoxemia or not, whether you need a right-sided device, which is Impella RP at our institution, Protect Duo, or if the patient is hypoxemic, you need to put an oxygenator, essentially put an ECMO, Protect Duo and oxygenator, or we put LV ECMO with a LV vent, VA ECMO with an LV vent. So that is supporting the right side. If your PAPI is more than 1 with a CPO of 0.6, that means your RV is doing okay. This is a left ventricle dominant issue. And if there is no hypoxemia, then an Impella would be okay. If there is hypoxemia, again, you would need to put the patient on an oxygenator. That means VA ECMO. And then you would need something to offload LV, which is Impella at that point in time. So it essentially the configuration would become ECPella. If your CPO is 0.6 or less and PAPI is less than 1 with the RA pressure of more than 15 and wedge of more than 15, then there is a biventricular issue. That's where, depending on whether the patient has hypoxemia or not, if the patient does not have hypoxemia, you do bipella or Protect Duo. Or if the patient has hypoxemia, then you put a VA ECMO and do a LV vent. So this is crux of what we try to do when we get a patient who comes to ICU, put a Swan, get the numbers, get your CPO, get your PAPI, get your other numbers, and then decide where is the problem. Is the problem LV, RV, or both ventricles? Whether there is added hypoxemia or not, and then decide on which device to use. So for the patient that we saw, the patient had OK PAPI, low CPO. It was an LV issue. We put an Impella 5.5 in the OR by our surgery colleagues, and the patient received that less than 4 hours after the initial hypotension, which is the intent. As you saw when I first described this case, it took 12 hours or more from the shock setting in to the actual intervention, which defines the outcomes. More time wasted there would lead to inferior outcome. So again, there are many kinds of different mechanical support devices. You can have a balloon pump. We don't use it often, except for if there is a vascular issue or ischemia in a patient. Tandem heart is something that, again, we don't use it as much. 2.5 was something that we used before. It gives you around 30 to 60% of total support in terms of cardiac output. We use predominantly Impella CP. We used to use 5.0, but we now use CP, which is done by our interventionalist, and 5.5, which is done by our surgeons with a graft in the axillary vessel. ECMO, you all probably know, more robust support in terms of flow, can provide oxygenation with an oxygenator, but more chances of complication, less durable, more bulky, more expensive. Centrimag is something that we use predominantly for right-sided support. We call it RVAD. Without oxygenator, it is RVAD. With oxygenator, it is again VA Optimo. We use that just because it becomes easy to take the oxygenator out and then it can still provide that support. These are some of the approaches. The idea here is whatever path is suitable and convenient to your institution and applicable to your patient, you use that. The idea is the destination, and that is where we need to focus on. So when you put an impella, and I'm talking predominantly impella, in the cath lab or the cardiac OR, the question that we need to kind of understand is, has your CPO improved? Has your mixed venous oxygenation improved? Has your cardiac index improved? Right off the bat, if there is adequate forward flow, all these numbers would improve. If there is not adequate flow, you would see those numbers not improving. Also, along with that, because you're putting a left-sided predominant support, you need to focus on how is your right side doing. What is your PAPI? That is the pulmonary artery pulsatory index. If it's less than 1.5 after you put an impella, then there is a RV problem. You're looking at something to be done for the RV. It could be transiently an inotrope, maybe a milrinone, but most likely you may need to escalate to a device which would be supporting RV along with an LV. So let's look at the same case. Now, this guy, after 4 hours of his shock, we met as a team. We decided to put an Impella 5.5, got an Impella 5.5. His maps were good, his numbers were good. 3 hours post arrival to the ICU, the patient became hypotensive. What is the most likely etiology of this patient's hypotension? The maps were now from 85, 45. And I know you guys are assembled there, probably cannot answer it well, but this was essentially a trick question. I did not give you adequate information, but the idea behind this was you didn't have numbers. The patient's numbers were CVP was 2, mixed venous was low, hemoglobin, which was 12, is now 8. And most likely etiology of patient's hypotension in this case was bleeding. What I'm trying to make you aware of is what are most common issues that you would encounter when you get an Impella patient in your unit. These are some of the most important and potential complications that you would see. Hemolysis, although not right away, but sometimes right away, you would see that. Arterial thrombosis is something that you need to be attuned to. Bleeding, as I described, is actually one of the most common things that you would see right away. Maybe the sheath came off or migrated, or maybe while getting an access, there was a retroperitoneal hematoma or hemorrhage. So, getting frequent labs, monitoring these patients. For example, for hemolysis, we check daily LDH. It just gives us an idea and a trend or trajectory to compare where we stand on a daily basis. If there is an acute jump in LDH, then it tells us that there is an issue. Thrombosis of the artery or blood vessel, and this is very crucial from the nursing standpoint, is neurovascular check. If you have an Impella CP or a 2.5 placed through groin, we need to be tuned to monitoring the pulses distally in the leg regularly, and if there is any acute change, notifying the team so that interventions could be done. RV failure, we'll talk more about it. Sheath complications, device migration. Unfortunately, that is a topic in itself, and I cannot like, given the short time frame. I would not talk about device migration, but that is something that we deal on a daily basis. We actually check every day with the ultrasound to check for the positioning of the impella and then maneuver the impella if it has migrated. So let's look at the same case again. The same 54-year-old guy, non-ischemic cardiomyopathy, impella. 3 hours after the ICU, patient becomes acutely hypotensive. But now I'm giving you some numbers. The CVP is 16, mixed venous gas is 45%. What do you think is the etiology of this patient's hypotension? Again, this is not a valid question right now. Obviously, I've discussed bleeding before, so unlikely that this is bleeding. But there are two possible reasons why this patient may have acute hypotension. It could be RV failure or it could be impella support, which is inadequate. So, how do you differentiate whether it's RV or whether it's inadequate impella support? That's when you need more numbers. That's where you need SWAN. This is your CVP RA pressure of 16, PA pressure of 24/16, wedge pressure of 14, mixed venous 45, and cardiac output of 3.0. With this, again, I'm distilling it down. This is our practice. We calculate CPO, we calculate PAPI, and based on that, the etiology is RV failure. And I'll walk you down through that. Uh, so, so coming back to this, so the CPO was less than zero point 0.3, and now this is despite us having a mechanical circulatory device. And if you have PAPI with a mechanical circulatory device which is less than 1.5, then that is an RV issue. So your RV is leading to your LV failing, and that needs, if you have one side support, which is impella for the left side, and you don't have hypoxemia, you may need to look at putting an impella RP or a Protect Duo because you don't need an oxygenator, so don't need an ECMO. But if you don't have impella RP, then you would need to change gears and put a VA ECMO, and then leave the impella in to offload the left ventricle. So that is how you would troubleshoot your numbers and the clinical situation with the help of SWAN, with the help of CPO, with the help of PAPI to kind of figure out what is where. Another example. So same patient 3 hours after the patient comes to the ICU is hypotensive. Now I've changed the numbers a little bit. So your RA pressures are 16, but if you note, your PA pressures are 50/27. Your wedge pressure is 27, mixed venous is 45, and cardiac output is 3.0. What do you think is the cause of patient's hypotension in this situation? Well, going back to the numbers, the CPO is 0.3 based on the numbers that I provided. PAPI is 1.63. The etiology of the failure is inadequate support or impella issues. If you note, I actually changed the impella now to impella 2.5 just to make it more relevant to your practice, wherein your flow max would be 2.5 liters. And that may not be adequate. Your RV is okay based on the PAPI. So again, come back to this. So CPO map into cardiac output over 451 watts. Abnormal is less than zero point 0.6. In our case, it was less than zero point 0.6, which was 0.3. The PAPI was actually 1.63, which is PA systolic minus PA diastolic with CVP in the denominator. So this is where we get stuck. There's no hypoxemia. So you need to upgrade your impella, or if you don't have a higher impella, you may need to do VA ECMO with the LV vent to offload the vent. So in your case, you may leave the impella in with a VA ECMO to to support the RV or the LV in this situation would be the way to go. So these were some of the examples I just shared in terms of day-to-day management, troubleshooting, numbers, challenges that you would face. As I mentioned, we predominantly use Impella 5.5, and most of our patients are bridge to transplant. So we have patients who stay with an Impella 5.5 for weeks to months till they get their transplant. And we need to kind of monitor them on a daily basis so that we are aware of what's going on. And this is what I've kind of mentioned in terms of what can possibly go wrong in a visual way. So your CPO in the first instance could be low because of RV related issue. I explained an example of RV failure, but you can certainly have a PE or with an impella can easily cause tamponade, which can lead to issues. You can have pulmonary hypertension leading to RV failure. You can have tachyarrhythmias leading to RV failure. Volume or bleeding can certainly also impact RV because your forward flow is impacted if you're hypovolemic. LV itself can can lead to low CVO. So you can have LV failure or impella, which is inadequate in terms of flow support or cardiac output support. But the other issue here is the impella positioning, which any intensivist who's managing impella should be able to, with an ultrasound, point of care ultrasound, be able to see where the impella is, whether it's migrated to in, whether it's stuck on a papillary muscle, or whether it's come out, and be able to adjust with a point of care ultrasound. And that is what we do on a daily basis to ensure that the positioning is okay. And then there are systemic issues, vasoplegia, acidemia, hypoxemia, sepsis, because this is a foreign body in the body, bleeding, which can all lead to drop in MAP, which could lead to both your LV and RV having an issue. So, so that's in a nutshell what you need to kind of keep in mind. Post implant management, it is very crucial once you have a device which is working to optimize your hemodynamics and optimize your metabolics. The idea here is not to kind of aggressively start dropping your P levels, but to have adequate volume. So get your CVV down, diuresis is the way to go. Get your wedge down, get your mixed venous up. You may need inotropes, but the idea is if you need inotropes, try to use one low dose or maybe two low dose to support both RV and LV. But if there is an increase or escalation of inotropes, that's when you know that something is not right. The support you're providing is not adequate, and you would need to change gears. What do you do post removal of devices? So, post removal of devices, we still monitor them closely. We keep them in ICU at least for 24 hours, keep the PA catheter in at least for 24 hours after we remove that. And then again, your regular management, diuretics, and inotropes if needed, and low threshold to refer to transplant center, which in our case, we are a transplant center. So again, that this part, post-implant management and post-removal management is a topic in itself. What do you do for anticoagulation? At our place, we use bivalirudin. What are the labs which you do? What is the mobilization program? What is the securement strategy in terms of how do you keep the device secure so that it doesn't migrate? All those are very, very crucial in maintaining the catheter in place so that it could be used for weeks or months together. So, just to summarize the clinical burns, I mean, early identification is crucial in terms of cardiogenic shock. Implementing temporary mechanical support early prior to significant escalation of vasopressor and inotropic support is also crucial. Invasive hemodynamics are essential. PA catheter, we believe, is the way to go in terms of getting you that number and the answer where you stand. CPO, as I mentioned, is a really good tool, can tell you a lot about the heart, along with PAPI. Coding a patient on TMS is a different topic altogether, but everybody needs to have a game plan in terms of what if a patient on an Impella codes or a VAD codes. Treating tachyarrhythmias and the cause of tachyarrhythmias is important. Wean Impella only after hemodynamics and metabolic parameters are near goal, and you are on a very low dose of inotropes. Management after Impella is just important as before. Assess for potential TMS related complications, as I mentioned, bleeding, clotting, thrombus formation, device migration, all that is really important. Uh, Identifying what type of shock is essential. So this is a nutshell the summary of what I tried to talk. This is just an example of three patients, not from our hospital, but were referred from outside hospital. And the hub and spoke model of even an outside hospital, they can actually call us. We can get them on a Zoom. We can discuss the patient and quickly send the patient, give them the appropriate device, and in some cases transplant to get them fixed, get them what we need to. We actually have posted pictures with the permission of the patient. This guy, in this case, this was a 36-year-old guy with acute myocardial infarction, cardiogenic shock. Ultimately, got a heart transplant and is doing well, and so on and so forth, and the other two patients. But just to summarize, this is just a workflow of our transplant program. We do both heart and lung. And as I mentioned, a lot of our mechanical circulatory patients eventually are destination to transplant. So it's kind of crucial to have that. This is our outcome, not just for Mayo Clinic Florida, but for the entire city of Jacksonville, where Mayo Clinic Florida is since we instituted this program from our 55 number for the whole city of Jacksonville, we in 2022 had 83% survival after cardiogenic shock. So that hub and spoke model, because we are the only center which does heart and lung transplant and these advanced devices, we have created a pathway for all these area hospitals to send us these patients and optimize their outcomes. I want to acknowledge two people predominantly. Dr. Pablo Morano Franco, he is the chair of our department, and a lot of these slides that I used were from him, and Dr. Parag Patel, he is the chair of our heart transplant department. Uh, they were instrumental in kind of doing this cardiogenic shock initiative, but this is the rest of the entire team. And it truly takes a village to get to where you want from where we started. So acknowledge that. I know we are 11:53, so we have 7 minutes, but I'm happy to stick around to answer more questions. I know I slightly went over the 45 minutes that I wanted to talk. So opening up to any questions, thoughts, comments that you guys have.
Thank you very much, Divan, for your lecture. It was great. Now we're going to open the room for questions.
Hello, Dr. Depan. Thank you very much for such a wonderful presentation across the board of cardiogenic shock. I am Dr. Arias. I'm head of cardiac ICU. And if we have some time left, I would like to ask a couple of questions. First of all, on patients who are on VA ECMO support and who develop signs of LV distensions, I would like to know what is your best unloading strategy for them.
Absolutely. So the question was, patient on VA ECMO, how do we unload? Historically, if so, it depends on whether it is a central VA ECMO or peripheral ECMO, VA ECMO. I'm guessing your question, or most likely you are doing peripheral VA ECMO, and the best unloading strategy in this day and age would be to place an Impella and change the configuration to an ECPella, that is ECMO VA ECMO with an Impella, to unload the LV. Obviously, you don't want flows of 5.5 liters. You may change the settings to say P3, P4, around 1.5, 2 liters, depending what your hemodynamics are, would be an ideal unloading strategy to unload your LV. That is what we do predominantly. Obviously, anatomy becomes an issue. 5.5 needs auxiliary approach. You need to cut down, put a Dacron graft, and then unload the thing. If this is not feasible because of whatever reason, then Impella CP or groin approach, femoral artery approach, is not long-term durable because of mobility constraints, because we like these patients to move. But if you're stuck, you would put a CP, but then there is more hemolysis, hemorrhage, and is not convenient. So ideally, we try to go either axillary artery and put a 5.5. Uh, Previously, we used to do percutaneous, perforation of the septum and those more barbaric things, which I think with Impella being more readily available, we can do the unloading very easily with that.
Thank you. Thank you very much. For the time being, Impella here is not up for grabs. I have a second question. From clinical trials, we learned that Impella was associated with a twofold increase in renal failure and that hemolysis might play a role. How do you tackle that problem in the field?
So that data is true, but that data is not true for Impella 5.5. So I've personally taken care of almost 50 to 75 patients with Impella 5.5. To me, that is the best device in terms of Impellas, with minimum hemolysis and maximum benefit in terms of flow. With previously, we used to use 5.0, we used to see more hemolysis. And then if you kind of use the other previous models of Impella, there is certainly a big concern with hemolysis, which results in kidney injury and all those other problems that you see reported in literature. But our data shows that with and Impella, I think, has become like a predominant pathway to support our pre-transplant patients while they wait for a heart transplant. And you know that organ availability is a big constraint. It is not easily available. The wait time could differ, and sometimes the patients are on Impella for months together. But with Impella 5.5, we have not seen acute kidney injury because of Impella per se. We would see AKI maybe because the support from Impella is not adequate. The perfusion is an issue, and we may have to escalate things to say VA ECMO, leave the Impella in to unload the LV. But that is a hypoperfusion ATN, that acute tubular necrosis related kidney issues, not per se hemolysis. Because, as I mentioned, we manage the Impella patient by getting LDH on a daily basis to see the trend. And if there is, say, hemolysis, most likely what we are seeing is maybe at the tip there is a clot or something, which we can potentially either by giving TPA or sometimes we had to replace it. But if you put a graft, a Dacron graft, and then float an Impella, that becomes a challenge to replace it. You may not be able to use the same side, then you may have to use the other side, which anatomically is not as preferable as the right side. But so just to answer your question, 5.5, less hemolysis, less kidney issues, better mobility, better overall outcomes.
Thank you.
Any other questions?
Thank you, Ivan. The mic was off, so I was speaking to myself. Thank you again for sharing your lecture with us. It was really very interesting. This is going to be available online. I think we're on the time, so thank you again for your time. And I hope we.
So Federico, one last
Yes.
thing I was discussing with Ivan. I mean, if there is interest in learning any of these parts further, we do have a thing wherein we actually, the Mayo team, several of our colleagues can go to certain parts of the world. We've done this for India. We're doing it for Vietnam. We're going to Panama to kind of give a focus kind of talk with whichever part of critical care, be it cardiogenic shock or whatever else that people are interested. We can certainly do that. If there is an interest, happy to talk more offline and we'll work that out.
Thank you, Ivan. Thank you so much for your time.
Thank you.